pushing complications and current concept. It starts from Codivella, 1905, who started using skeletal traction, then Abbott. The real breakthrough was Elizarov.
دكتور جمال بيستأذن حضرتك لو ممكن نعلي الصوت شوية بعد إذن حضرتك.
شكرا. The real breakthrough was Elizarov. There is no doubt. We started working by Elizarov in 1983 in my university. Professor Kazem brought everything, even the hand stuff, to our department, and we started working 37 years ago. I published this paper in the Journal of Orthopedics and Traumatology, the official journal of the Orthopedic Association, the Italian Orthopedic Association, about my points of view of limb lengthening. And if you are interested, it's an open access, so you can get it if you want to. If you think to old Egyptian history, there was special treatment for the short people or dwarfs. Many of the divine protectors in their pantheons were deformed. This is God Bes, and this is God Betah. You know the belly dancing. Belly dancing is, is very old in the history of Egypt. And you see in the temple, all the belly dancers are tall, except the short one. You see the short one. They were treating all the people the same. There was no discrimination 5,000 years ago. This was the real humanity. How they were dealing with the short people. Snip. Snip was a very important man, very rich, very wealthy. It's like a prime minister at that time. He was a chondroplegic. You see the temples. He was married to a normal tall girl, and he has 2 children, normal children. This is how they were treating the handicapped and the short or the dwarfed people in old Egypt. You see the butcher, very short one. Musicians, they were all having normal jobs. So actually, that's why the old Egyptians or the ancient people were not famous about bone lengthening. They didn't need bone lengthening. What's the aim of bone lengthening? Limb length and equality. You want to equalize the length. You want to have a functional improvement or cosmetic. There's nothing wrong with cosmetic improvement. And this is an example of lengthening and deformity correction. Very short segment and rotational deformity, 180 degrees. This is the patella and this is the heel. So the heel lies in front and this is the patella. So we did lengthening here and rotational. Rotational, it looks like lengthening in this direction. You see with the derotation and lengthening at the same time. The picture before and after. Again, this is lengthening on both sides. You see 110 degrees, 110% of the original length of the hand, forearm. Sometimes it's also changing lives. You see, this is traumatic crushed amputation of the foot, which had been treated microsurgical and it worked out. So we had to do 22 centimeter lengthening, more than 100% lengthening. You see. So sometimes bone lengthening, again, is changing lives of the people. Nothing wrong with cosmetic lengthening, you see here. About 10 centimeter lengthening, nothing wrong. It's very cheap here if you want to do it, cosmetic lengthening, and we do it for ordinary people. They are farmers, so there is no problem at all. She's 130 centimeter length, and she wants to have lengthening on both sides. You see, it's not a fancy operation or something. The biology of lengthening, it depends upon the general biologic law, tension stress of Elizarov, nothing new, which is gradual traction on living tissues, creates stresses that can stimulate and maintain the regeneration of active growth of certain tissues. So if you have an adequate blood supply, you can have a regenerative, which develops along the axis of the applied traction. This is the traction. Along the axis, you have the regenerative. Corticotomy. We believe in corticotomy. Some people don't. They do osteotomy. Actually, we believe in corticotomy, that you don't disturb the blood supply. The biology in 3 stages. The latency period, corticotomy, and you wait from 5 to 15 days, then gradual distraction and consolidation. The evolution of limb lengthening has 2 wings: evolution in the devices and the biologic solutions. Most of the people are interested in the devices, which I think it's not that important. The most important is the biologic solutions. The evolution of the biologic solutions, or to stimulate the regeneration area. Most of the people complain of the long time till consolidation. This is the real complaint of the patients. So we have many advances: systemic, the use of bisphosphonates, high dose of alendronates, calcitonin, nerve growth factors; local, bone morphogenic proteins, platelet-rich plasma, and stem cells. Still in the infancy, but we think this is the real evolution. For the devices, we started from skeeter traction, unilateral fixator, circular fixator or Elizarov, computer-assisted as TSF, hexapod, and finally the internal bone lengthening nails, Albizia, ISKD, then finally fit bone and precise. We have many techniques regarding the implants. Lengthening, then nailing, we don't use it because of the pentrack infection, because of, if you have 1 case of deep infection, you will never do it in your life, because you have this danger of infection, and you had 1 case. Lengthening over elastic nails, lengthening over submuscular plating, or lengthening the plating. Again, if you have 1 case of infection, you will never do it again. And we had 1, 2. And the internal lengthening devices. We're not going through this, starting from Albizia till the magnetic precise nail. What are the indications of limb lengthening? Again, it's very controversial because people put the rule. If you have less than 2 centimeters, you don't do lengthening. From 2 to 4, it's the gray zone. And after 4, it's absolute indication. We don't think so. We lengthen some people because they have 2 centimeter shortening, but they have short heel. And they're limping. Can you imagine limping? Quite apparent limping in a girl because she had only 2 centimeters, but she had very short heel in some cases, which adds to the shortening. Dwarfism, cosmetic limb length discrepancy. The indications for the motorized nails or magnetic nails are a bit different because we have some problems of limits. You have limits for acute deformity correction. You cannot have significant deformity corrections with nailing. If you have previous infection, nobody speaks about previous infection. I don't know, perhaps because the infection in our area is far different from the infection in the Western world. It's far worse. The diameter of the bone, it's very important. You have a very small diameter. Can you put a nail? The distance. Because for me, 8 centimeters is a short distance. Many of our people, they need more than 8 centimeters. I know that some people, they take the patient to the operating again and they change the distractor to have more lengthening. But again, you have a short segment, which is biomechanically not good enough for the stability. And this is an example of fibular hemelia. with a deformity and shortening, and you do both gradually at the same time. Complications. It's a huge talk, and we are preparing now meta-analysis about the complications, how they are related to the surgical load. When the people speaks about prosthesis, total knee, total hip, they always speak about the surgical load. This surgeon or this hospital is doing 500 cases per year. This hospital is doing 1,000 cases per year. Or this surgeon is doing 50 cases per year, so he's a casual surgeon. You cannot count on his experience or something. But if you come to lengthening, it's a bit strange. Look to the papers. This paper by Lascombe, it speaks about 32 cases by over 30 years by multiple surgeons. So each surgeon experience is something like 0.2 patients per year. And they are giving us their experience, for the God's sake. How can you give you your experience and your experience is 0.2 patients per year? Anyhow, look to the other paper. Over 14 years, they are doing 39 cases and it is multi-center. So the surgeon experience is 0.1 patient per year, but they are giving us our experience, their experience. A bit strange. In general, the complication, the most important complication is pin track infection, which is quite possible with external fixator, poor degenerate formation, premature consolidation of degenerate axial malalignment for long distances. And look, this case of malunion, which had been treated by lengthening before. We did osteotomy in the same place or in the degenerate here. And debridement lower there and compression. And we had premature consolidation of the degenerate 2 times in this patient. There is no rule at all. This is premature consolidation, you see here. And in such a case, we continue the distraction till breakage occur or something like closed osteotomy. And we had another premature consolidation. When we reached our target of lengthening, we had this severe deformity because of the very strong muscles. And we did gradual correction. We applied distractor from the medial side and hinges from the lateral side till we corrected the axis of the femur. And we had, in this 42 years old man, another 11 centimeter femoral lengthening. When we do lengthening, as you see, we try to avoid the common peroneal by applying the wire from the fibula, as you see here, and we continue till it's flush with the fibula. So you don't come closer to the common peroneal. When you look to the intramedullary nails, we have many complications. We have too many complications. Actually, they show us the complication at the end of the patency. So usually, when each type of nail continued for 9 years, in the 10th years, they started to show us the complications over the years. What are the complications of precise nail? Now I'm preparing, we are at the end of it, a meta-analysis about the complications of the precise nail and Baumgart nail on the feet bone. And I will show you how we are biased towards doing the intramedullary nails. And the complications are not the same like external fixation. It's far worse, especially if you have infection. Physiotherapy. In our patients, we don't have a specialized center. I see on the internet that this is the most important specialized center for limb lengthening, and this is the most important specialized center for limb lengthening. You can find many of them on the internet. We don't have a specialized center. We treat the patient individually, and you see here. We allow the patient to go to the swimming pool, to the shore, and to walk, use the computer. It's an individual work. Hospital stay, only 1 day or few hours. Most of the cases, they leave the hospital in the same day to decrease the costs. For achondroplasia, you have many cases of achondroplasia, many cases of achondroplasia. Most of them are very poor. What we usually do, we have the first lengthening at age 5, this patient, and we did femoral at age 9, second lengthening tibial 11, humeral lengthening 15. We finish before going to the university. Very important point. Because we think that the psychological problems come when the patients, they go to the university when they are 16. We try to avoid everything before the adolescence, before the psychological problems. So we finish at the age 15, even the humeral lengthening. And this is an example of this girl, tibial lengthening for 17 centimeters. Both sides, we have axial malalignment, and we correct it gradually. Femoral lengthening, about 12 centimeters. Femoral and tibial. She came late for humeral lengthening on both sides. For 10 centimeters. Not only for cosmetic reasons, because of the function too, because she needs to have enough length of the forearms because of the humerus for the perineal hygiene. This is 53 years old female. She's a professor of medicine with achondroplasia. I advised her about lengthening, but she came 20 years later at the age 53 because of the severe deformity and started to feel that she will never be able to walk. We did bilateral corticotomy and lengthening. There is no age limit. For cosmetic lengthening, we have to think about the reality and the expectations because sometimes they are not the same. Psychiatric evaluation is mandatory for our patients to exclude body dysmorphic disorder. And usually we have longer distances for lengthening, not 5 centimeters or 4 centimeters. We don't know this. We see in the papers how they lengthen for 4 centimeters or 4 centimeters. Not for our patients, not for our patients. For the upper extremity lengthening, we have many cases for upper extremity lengthening, and we didn't notice any deterioration of the function. The indications, again, for the upper extremities are controversial: achondroplasia, hereditary multiple exostosis, physeal growth arrest, amputation, infection, shortening from trauma. You see here it's trauma and Erb's palsy, both of them with 10 centimeter humeral shortening at the end of distraction. And you see here forearm lengthening, 110% of the original length, and we didn't have a problem. Phalangeal lengthening, we use penic fixator most of the time. It's easier. Phalangeal lengthening, metacarpal lengthening. Do we have a limit for lengthening? Yes, I think in the English literature they speak about 20% because they have an experimental study on rabbits, and in rabbits, when they lengthen them more than 20%, they have more complications. And you all know that we are not rabbits, so we don't follow this rule. And this is an example in congenital problems. If you have a tibial hemimelia, and we gradual descent of the fibula, and this is lengthening for 10 centimeters with more follow-up, more lengthening for 10 centimeters. You see the range of motion. Not 20% at all. Most of the complications reported in the English literature are hypothetical. It's not coming from doing large number of people or something. And this is the end picture. Humeral lengthening again. I've learned it from the basics at again 20%. And this is one of my early cases with the deformities, lengthening. You see again, 115% of the original length Nothing happened to the shoulder, nothing happened to the elbow. Because the people, they dealt with the humerus as a femur. The humerus is not a femur. Again, do we have a limit, 20% for lengthening? You see here, this is crushed, amputated foot. And the surgeon, for microsurgery, they removed all the segment to have shortening to allow for grafting and repair. And it worked out for them, but after 6 months, they presented to me with non-union and malalignment and severe shortening. We did corticotomy with comminution. Perhaps it was okay for comminution. 5 centimeter lengthening, 10 centimeter, 15 centimeter, 22 centimeter lengthening, and in union and correction of the deformity. So 22 centimeter lengthening, there is no place for the rule 20% or something. Finally, what about the experience? Again, when you see, for one reason or another, with the COVID-19, we started to search more for the internet. And I started to write limb lengthening, or I've seen hundreds of people speaking that they are the greatest, they have the greatest experience in limb lengthening in the world, not one. Unfortunately, most of them in the Western world speak that they have the greatest experience on earth in limb lengthening. But what's the surgeon volume? What's the surgeon volume? What's the hospital volume? Most of them, they said they have great experience in cosmetic lengthening. Do you think cosmetic lengthening is a real experience of limb lengthening? Just putting a corticotomy and putting the frame or putting a nail, and you call yourself an experience? If you look to the indications of limb lengthening in our area, 1/3 of the population are under the age of 15. So you have lots of problems, congenital problems, because of the young age. High incidence of neglected problem, high incidence of congenital deformities, conflicts. We have high incidence of the victims of conflicts, which they require lengthening and deformity correction. So if you think about the experience of limb lengthening, after my trip through the internet in the last 3 months, with the quarantine and staying at home for such a long time, think about which field. If you are doing limb lengthening, is it allowed for you, if you do 300 limb lengthening, cosmetic lengthening, is it allowed for you to say that I'm the greatest experience in the world? Many surgeons, they do only cosmetic lengthening, just cosmetic lengthening. Many of them, they are doing, I think the number of advertisements they do on the internet is far more than the number of the cases they do. And do you call this experience? Remember again, if you see this list of complications, the surgical load of each patient, is it 0.1 patient per year? 0.02 patients per year? In conclusion, limb lengthening is a rapidly developing field of orthopedic surgery. Currently, it's a standard procedure with predictable results, and indications have been extended to include the upper extremities and the cosmetic lengthening. I think experience has a great impact on the results of different procedures, because follow-up and management of expected complications are cornerstones of treatment strategy. Unfortunately, the English literature has many papers with relatively few number of patients operated on by many surgeons over such a long period. This means the experience of the individual surgeon is based only on one or few cases per year. Sometimes it's difficult to get valid conclusions from the reported mixed data. In spite of the introduction of the promising intramedullary lengthening nails and computer-assisted external fixation, we still count on Elizarov biologic law. They are all based on Elizarov biologic law. Biologic advances through research to stimulate regeneration and reduce the period of treatment will be the real revolution in the limb lengthening surgery. I believe so, that the real breakthrough will be the biologic advances. How are you going to minimize or to shorten the time till consolidation? If you are interested, you can read my 37 experience in this paper. It's open access. It's published this year. Thank you.